Good morning, everybody. Thank you, sirs, dear Mr. President, dear colleagues from the Chinese Orthopedic Association, dear colleagues from the NAS. Thank you for having me here. It's a great honor. I want to talk about the moving of spine surgery. In the last years, the spine surgery moves to increasingly atraumatic procedures. Already 5 years ago, a good friend of mine, Christoph Birkenmeier from the University Hospital Orthopedic Surgery in Munich, pointed out in a review, and he concluded endoscopic spinal surgery is increasingly popular because it minimizes access trauma and hastens recovery from the invitation.
Sorry. 那么他首先非常高兴组委会 COS NAS 组委会以及主席的一个邀请，能够让他有机会来参加这样一个非常好的课程。那么他今天跟大家介绍呢是关于脊柱的一个微创手术。那么在几年之前呢，他的一个好朋友也在非常有名的杂志上发表了一篇文章。那么他主要的结论呢就是目前的脊柱微创的或者是无创的手术呢是越来越流行，也实施的越来越多。
The most atraumatic way to reach the spinal canal is the transforaminal, but it has its limitations. And I want to focus, the special limitation is how to decompress the dorsal spinal stenosis.
那么传统的进行这个无创的方法呢，是通过经椎间孔的一个减压，但是通过椎间孔减压也有它的一个缺点。那么最主要他觉得缺点呢，就是对椎管背侧的一个减压可能是不充分的。
So let's focus on the interlaminar approach.
那所以我们看看一个经椎板间的一个入路。
The indications for the interlaminar approach are facet hypertrophy, spinal stenosis, foramen stenosis, and flavum hypertrophies, and the dorsum facet cyst.
那么经椎板间入路的一个主要的手术指征呢，包括一个关节突关节的增生，一个椎管的一个狭窄，一个椎间孔的狭窄，包括黄韧带的一个增生钙化。那么还有就是我们椎管背侧的一个囊肿的形成。
So it's quite easy. The more posterior the pathology, the more interlaminar you should go.
那么如果在病变越严重的时候呢，你越需要这个能够进行一个充分的减压。
The pathology of the degenerative spinous disease is quite simple. It starts with a disc degeneration.
那么蜕变性的脊柱疾病呢，它的其实病理过程并不复杂，那么总归是从这个盘源性的这个蜕变开始的。
That leads to an increased micromobility of the adjacent vertebrae.
那么导致临近阶段的一个椎体呢出现一个活动度的增加。
And that could lead to the facet syndrome, the disc herniation, and at least to the neuroforaminal stenosis and the spinal stenosis, and maybe to spondylolisthesis.
那么从而出现一些小关节的症状，一个椎间盘的突出，那么最终将会导致椎间孔的一些狭窄，椎管的狭窄，甚至一些滑脱。
The back muscles are very important for the stability of the spine. They are guided into fascias, and the fascias are fixed to the bone. And if you bend the muscles, that leads to alignment of the vertebrae.
那么其实脊柱的这些肌肉结构是非常重要的，那么它们很多时候是由这些筋膜来决定它们的走向和张力的，所以说它们同时对维持脊柱的这个力线也非常的重要。
In a research, they pointed out that the trauma of the back muscles is not only focused on that segment you operated, it's over a wide range of the vertebrae. It's also the neighborhood levels are involved.
那么大量研究也显示，其实你在进行脊柱手术的时候，对肌肉的破坏不仅是局限于你实施手术的这个阶段，那么对其他临近的阶段，其实肌肉的破坏也是存在的。
This study examined how many muscle fibers are collectible after surgery.
这个研究呢显示呢，对于不同的手术，那么你究竟要牵涉到损伤多大程度的一些产生多大程度的肌肉损伤。
So the most important muscles for the stability of the spine are the multifidus muscles. They are the stabilizers of the spine.
那么我们看到研究发现呢，其实对脊柱最重要的稳定结构呢是这个底棘肌的一个它的功能，它是维持脊柱的力线和稳定的最主要的结构。
and you should protect them.
那么你术中呢一定要保护它。
All classic approaches to the spinal canal detaches the multifidus tendon.
那么所有以前的开放性的手术呢，都会在术中呢去暴露以及损伤到这个底肌肌的肌腱。
Only percutaneous endoscopic procedures save this tension.
那么只有在经皮的手术或者是微创手术中呢，我们才能很好的保护底肌肌的这个解剖。
So the aims of decompression of a spinal stenosis must be as much decompression as necessary and as less destabilization as possible. So therefore, keep the approach as small as possible.
那么对狭窄的椎管进行减压的时候呢，一个原则就是要尽可能多的减压，但是呢要尽可能少的破坏脊柱的稳定性。那么同时呢，我们的入路切口应该尽可能的要小。
So the pathology is a result of a ligamentous overgrowth, disc bulging from the anterior, and the facet hypertrophy from posterior.
那我们看到其实这个椎管是有一种病理性的形态，有点像这个三叶草的形态，因为它的前方有这个韧带的一些增生，那么后方的关节突也有增生。
And we have two different problems that we surgeons have to solve. The first problem is the outside problem, how to reach the spinal canal, because in some kind of spines we have massive hypertrophies of the facet joints. And then that lead us to the inside of the spinal canal. Here's the problem, the large facet as well, the bony problem, and the soft tissue problem of the thickened yellow ligament.
那对于我们脊柱外科医生呢，我们要考虑到两个因素，一个就是椎管外的因素，因为很多小关节有非常严重的增生，那我们怎么样能够进入到椎管？那么当进入到椎管的时候呢，我们考虑到第二个因素，就是在椎管内，我们要考虑到怎么样去处理增厚的这个黄韧带，怎么样去处理椎管内的这些软组织。
So these are the normal types of decompression you all know, the classical ways, bilateral decompression, and in newer times, the single side decompression with the crossover decompression.
那这是我们非常经典的、经常用到的一些减压的方法。那么有包括双侧的减压和单侧的减压。
These are the techniques in the classical way. You just drill away the bone under the safety protection of the yellow ligament, and you come crossing over to the opposite side, drilling bone away, and then, and the last step, you resect the thickened ligament.
那么这是传统的，我们知道传统的减压方法。那我们去除掉关节突，打开黄韧带之后进行减压。
And these lead us to some challenges. First, we need new instruments. We need new techniques. And for the surgeons, we have to get used to these new techniques. We have to learn them. We have a new learning curve.
那如果我们想实现微创或者无创的话，我们需要在两个方面进行改进。第一个就是我们需要新的技术、新的器械；第二个呢，就是我们的医生需要掌握这些新的技术和器械。
When I started in 2008 with spinal surgery, endoscopic spinal surgery, this was one of my teachers, Thomas Hoagland. I had a very simple system. And the only thing what I did is soft tissue surgery. This is a disc herniation at level of 5/1. And this is the result of the surgery.
那么我第一次接触到脊柱的内镜手术呢，是在2008年。那张照片呢，就是他的导师。那么当时器械非常简单，他们也只能进行一些软组织的手术，比如说像这个病例，就是一个单纯的一个这个药物敌意的一个偏左侧的椎间盘的突出。
And we had since the 80s, we have more than 20 years of hernia surgery, only hernia surgery. And no development in spinal surgery.
那么对于内镜呢，其实从80年代开始发展，经过20年呢，其实还是停留在仅能进行对于椎间盘的一个手术。
But this is not real life, because most of my patients I see suffer from stenotic, bony problems.
但其实椎间盘只是一个很小的问题。那么他发现呢，其实他70%的病人都其实是因为有狭窄的这个病变来就诊的，所以很多是一些关于骨性的问题。
So the industry develops two spinal endoscopic system. In the upper part of the picture, it's a bigger laminoscope with a wider working channel. It's very good for the resection of massive bone hypertrophies. and the lower one is a longer one, a smaller one is perfect to work within the spinal canal to come to the opposite side and then decompress the opposite side as well as the ipsilateral side.
那么所以呢，他们发明了新的一些器械，主要是内镜。那么上面这个呢是一个大直径的内镜，是有10毫米的一个直径。那么它主要的作用呢是能够去除建立比较大的一个工作通道，那么去除更多的骨赘。那么下面这个呢是相对小直径的一个内镜，那么它的好处是在椎管内呢能够很容易的到达对侧进行一个手术减压。
So the indications I already mentioned, and on demand of our surgeons, the industry develops new types of instrument. When I started, I had only forcepses. Now we had drills, we have Carrisons, we have special types of rod to remove the soft tissue from the laminars. We have endobipos. We have everything a normal spinal surgeon will use in classic surgery as well for the endoscopic surgery.
那么器械的发展呢，内镜器械的发展其实非常迅速的。当他刚开始接触内镜的时候呢，他只有咬钳。那么现在呢，有各种各样的磨钻啊、钻头啊，包括像子弹头这样的磨钻，各种各样的器械。那么开放手术中有的，那么内镜都应该有。
So, and the challenge for the surgeon is to have a new learning curve because the techniques how to perform surgery are different to classic surgery.
那么但是呢，牵涉到医生的一个学习曲线呢，会相对比较长，因为他的操作呢和传统的开放手术完全不一样。
But sometimes it's easier. You have a much better visualization. You can look around the corner, but you have to get used to it.
但是呢，它其实是有它的优势的，因为通过这个内镜呢，有时候你能看到你开放手术中看不到的一些角落，但是呢，你必须慢慢的逐渐去适应它。
And sometimes it's simpler because only you move the instrument. You don't have to tilt the table to look on the opposite side.
同时它还有一个优势呢，就是传统手术中呢，你想看到不同的方位呢，你可能需要旋转这个手术台，但对于内镜呢，你只要旋转内镜就可以看到不同的位置。
So the visualization is excellent, but it's different to classic surgery because you have a puzzle of different pictures.
但是你的这个视野呢是和传统手术不一样的，因为你看到的是不同的一个不同地方的都是一些局部的，不是一个像开放手术一样的看到的是一个整体。
Let's come to some examples. Central stenosis, undercutting to the opposite, opposite recess decompression and inner foraminectomy, and removing of an intraspinal cyst.
我们接下来看一些例子，主要是一些椎管的减压，包括对侧的一个减压、关节突的一个减压，还有这个背侧囊肿的一些切除。
So as I already mentioned, the first step is to bring in your rods, your working tube, and the endoscope to drill away the lamina, and then to come to the opposite side under the safety protection of the yellow ligament, and to resect the recess bony structures, and then to resect the yellow ligament.
那么达到内侧呢，我们需要把这侧的关节突磨掉，然后呢，通过在黄韧带外的一个安全的区域呢，到达对侧。
Especially in elder patient, the resection of the thickened ligament is for me the most important step in the whole procedure.
那么对于我来说呢，怎么样去处理这个增厚的黄韧带，如何进行减压，是整个操作中最关键的一步。
So this picture show how far you can go to the opposite side with the examining hook.
那么这张图呢，可以看到我们用探针直接可以到达对侧多远的地方。
This is the undercutting to the opposite side, how to position the working tube over the top, over the thecal sac.
这张图呢，我们显示它是定位在一个增厚的韧带的地方。
On the left picture, you see the ipsilateral approach, and on the right picture, coming up to the opposite side.
那么左侧呢是它一个入路，右侧呢是它到达了对侧。
That's the resection before and after the result is on the right side.
那么这是术前和术后，它到达右侧的术前和术后，它经过右侧是减压之后的。
This is the opposite side, recess decompression, inner foraminectomy. You can open the foramen from the inside. But I mentioned the most effective way to open a bony closed foramen is to come transforaminal. It's much better. But it's possible to do it interlaminar as well.
那么如何进行一个椎间孔的一个扩大呢？它往往是要从内侧进行一个扩大，但是呢，同时也可以经椎板间入路进行椎间孔的一个扩大术。
So you can work within the whole spinal canal with a stitch of less than 1 centimeter.
那么你可以呢，实施这个手术，这个椎间孔的扩大手术，只需要一个1厘米的一个
And this
通道。
is as small as possible. We can't be more smaller.
那么这是一个极限了，你不能再小了这个通道。
Here's another example, an intraspinal cyst. We say nowadays we say intraspinal cyst. Before we say flavum cyst, facet joint cyst. Now international, we came to the conclusion to say we have an intraspinal cyst. This is an intraspinal cyst, and the lady suffers from an L5 massive pain syndrome.
那么这是一个女性疼痛的症状，那么主要发现的是145的一个椎管背侧的一个囊肿，并不是黄韧带和关节突上的一个病灶。
And these are the steps with some videos. Here is the opening of the cyst. It was a flavum cyst.
这是对黄韧带进行处理。
Inside you see the thecal sac already moving, intraspinal fatty tissue.
那么去除掉一些椎管内的一些脂肪组织。
Here is how you work with forceps, punches, and drills.
那么用咬钳以及这个
The
钻头磨
resection
钻。
of the thickened flavum with a forceps and then with a punch, a Carrison punch, as you are used to in classic surgery.
那么和传统开放手术一样，对于增厚的黄韧带呢，用咬钳或者是用钻头把它去除。
And then as a last step, to widen the bony decompression with the drill and again with the Carrison punch.
那么是
Here
对
you see the thecal sac has started pulsing. You see the intraspinal fat tissue. Now I widen a little bit to the lateral side with the drill, with the diamond burr under direct visualization. You can come close to the thecal sac, nothing will happen.
那么它接下来呢是用一个磨钻钻头呢，对骨性的一些狭窄的结构进行减压。
And this is the result. The 3 thecal sac pulsing, the cyst is gone, and the patient was pain-free. So I come to the conclusion. The interlaminar endoscopic approach to the spinal canal is a further traumatic minification of the classic approach under greatest possible preservation of the stabilizing back muscles and a far better optical visualization, as for example with the tube system or a microscope.
那么我们最后对这个经椎间板的一个内镜入路呢进行一个总结。那么这样一个技术呢是对在传统技术上的一个发展，以及它目前呢也发展的非常迅速。那么它的主要优势呢是还是对后背肌肉的一个保留以及更好的一个操作视野。
Thank you so much.
谢谢大家。